you everyone for joining us and apologies about the technical difficulties. We're trying to get Dr. Gholam to join us as our moderator. I'm Dr. Naeem Al-Khoury, Chief Medical Officer at Arizona Liver Health, and it gives me great pleasure to be part of this roundtable webinar on rare diseases. We will be discussing two very important topics, Wilson disease and progressive familial intrahepatic cholestasis, PFIC. We have my co-presenter is Dr. Fred Askari, MD, PhD. He's a clinical associate professor at the University of Michigan, an expert in Wilson disease, and he is part of the Wilson Disease Association Medical Advisory Committee. And then we are also joined by Alice Williams, who's a board member and executive committee, Wilson Disease Association board member of the Canadian Organization of Rare Disorders, and patient partner with the University Health Network. We're also joined by Emily Ventura, who's the executive director of the PFIC Advocacy and Resource Network. So to get us started, I'll hand it to Dr. Askari to educate us about Wilson disease.
Oh, thank you so much for your kind introduction. I'm Fred Askari, and I'll be talking about Wilson disease. These are my disclosures. I'm involved in clinical research in Wilson's disease and discovery. I'm going to go over Wilson's disease therapies, presentations, and diagnosis, the evolution of therapies, current medical treatments available, pros and cons, as well as briefly touch on liver transplantation as a last resort. Wilson disease was first described in 1912, and this is a paper from Brain by Kinnear Wilson. Basically, it was a brilliant descriptive manuscript that went over what was involved in Wilson disease, this disease that involved the liver and the brain. And for those of you who are publishing papers, you'll notice it was over 200 pages long. So it was really more of a book than a paper. But back in 1912, the journal was delighted to develop this brilliant thing that today would be a PhD thesis on Wilson disease, and basically it was basically a description of what happened to these patients, how they presented, and how they went on to pass away. The Copper Association was first discovered in 1948, so it really took a long time from 1912 to 1948 to figure out this was due to copper. The first treatments came shortly thereafter. Bowel was developed in the 1950s to 60s, and then penicillamine was approved as a first-line treatment. Trientine came along as a second-line treatment or salvage therapy for those who failed penicillamine, this was available fairly shortly after penicillamine because penicillamine was so toxic. There were a lot of patients who went on to have problems with it, and Dr. Welsh discovered trientine as a rescue agent. And then zinc was first studied in the 1960s and approved by the FDA as maintenance therapy in 1997. So this is the current state of approved treatments for Wilson disease. So not much new in the last several decades in terms of approved therapies, although there have been a lot of research. So copper toxicity is the hallmark of this disease. And it affects the liver with histology ranging from normal to mild inflammation, steatohepatitis, glycogenated nuclei, cirrhosis, and liver failure, on to acute liver necrosis. There's neurologic movement disorders, psychiatric illness, and then another hallmark of the disease are Kaiser-Fleischer rings in the eye. So the diagnosis is made based on urine copper testing, which tends to be elevated in this disease, serum ceruloplasmin levels, which can give a further clarification of the disease or raise suspicion of the disease, although it's not a perfect test, so we shouldn't be overly spoiled by the ceruloplasmin, thinking whether it's low, that means the patient definitely has it, or if it's normal, they definitely don't. Serum copper assays, which are paradoxically low in the chronic presentation, even though the body is total body copper overloaded, the blood levels can often be low at presentation, except in the fulminant presentation where they're often markedly elevated, and sometimes in the acute on chronic presentation they can be elevated as well. Liver copper quantification is considered by many the gold standard for diagnosing Wilson disease. It requires a liver biopsy, and the sample will be placed in a trace element-free container and analyzed for copper quantitation. Histology, as I mentioned before, is nonspecific, so that often can throw you off the diagnosis because the copper stains are not very good. KF rings can be present and at a higher frequency in those with neurologic disease. Over 90% of patients with neurologic disease will have KF rings, but only 50% of people with hepatic presentation have KF rings or less the earlier on in the presentation. And so it's not, again, something that the presence of KF rings shouldn't definitively rule in or rule out the disease. MR shows copper damage rather than copper. Copper is not ferromagnetic, and so we're kind of spoiled that we could see iron in the liver, but we can't see copper, and so that's an important point to point out. And then genetic testing is becoming more and more available and used more widely in diagnosing Wilson disease, and so that's quite useful as well. There are many mutations, though, over 600, and so interpreting the genetic testing can take some effort, and it's not always, again, a yes or no question. The calculated non-ceruloplasmin copper is often negative, which leads to confusion. It's fraught with measuring and calculation error, and so the field is likely to have a funeral for this measurement of non-ceruloplasmin copper, as better assays are already becoming available. One of them through the Mayo Clinic currently, the labile-bound copper assay, and so there are likely to be others coming soon as well. So clinical recognition of this condition is a major problem. The types of presentations include neurologic, psychiatric, hepatic, asymptomatic, in other words, patients diagnosed because they have a sibling who has it, or now on genetic testing prior to birth, even it's being diagnosed. And so there can be genetic screening as well, or people are getting gene tests for hundreds of genes and finding they have Wilson disease or carry Wilson disease. So testing, people can present at all stages in this disease, and even within the subsets, there are dramatic differences. So in terms of neurologic presentations, and people can have a combination of all. Someone can present with liver failure, psychiatric symptoms, and neurologic symptoms. So I don't want to make it sound like these are discrete boxes either. In terms of neurologic symptoms, it's a movement disorder or tremor, which can be arresting our attention. As one of the most common findings, people can also have dysarthria, trouble speaking, dysphagia, trouble swallowing, dystonia, bradykinesia, slowed movements, trouble walking, and a gait disturbance. The typical wing beating tremor that, people will show a video of someone doing this and say, this is a typical tremor of Wilson disease. We see it, but rarely. I don't want to make you think that everyone who has Wilson disease has a wing beating tremor, and that's why I'm always reluctant to talk about it as a pathognomonic sign for Wilson disease, because it's just, even in patients with neurologic disease, it's not seen in the majority of the patients. Cognitive decline in function can occur, and disrupted object relations can occur. So oftentimes people have fractured personal relationships if they have advanced neurologic disease. Again, many patients will not have neurologic disease, so I don't mean to imply that anyone with Wilson is going to get all of these things. These just can be, the presentations can be quite a spectrum. Similarly, in terms of psychiatric symptoms, People often present with anxiety, depression, difficulty concentrating, bipolar symptoms, psychosis, disinhibition can be a hallmark finding where, in effect, people say what they think or think what they say, without filtering it, can be a problem. And there can be times of decreased executive function, difficulty, organizing and managing things, and hyper or hyposexual activity can also be a feature. But again, I don't want to, lead you with the impression that everyone with Wilson's disease is going to get these symptoms, because many of them don't. Many of the patients are very highly functioning, physicians, attorneys, school teachers, et cetera, that manage very complex things well. So that's not to say that everyone does. And then there's a hepatic presentation, as I talked about. Can present really with a range of presentations with normal liver enzymes, particularly on family screening. Someone sibling finds out they have it, they go get their blood work checked, and they say, well, my liver enzymes are okay, I don't have it. Obviously, that's not the case necessarily. Their liver enzymes can be normal in Wilson disease. Generally, a transaminitis if the liver enzymes are abnormal, and hints can be in a mild unconjugated hyperbilirubinemia or a low alkaline phosphatase. Again, can be seen. Cirrhosis, obviously, we should think about this disease with anyone who has unexplained cirrhosis, or even if they do, drink, that doesn't mean they don't have Wilson disease. So those are good things to be aware of. All the presentations of decompensated cirrhosis, ascites, hepatic encephalopathy, bleeding, varices, hepatic hydrothorax, those can all be seen in Wilson disease as well. And then there's an acute presentation, which means that someone who is doing well, it's obviously they probably have chronic liver disease, but they're unaware of it. And then they have an acute on chronic decompensation, and this can be the young, 19-year-old is out playing soccer in a heat and gets dehydrated and goes out and has a few drinks afterward, and the next day they're in the ICU with a fulminant hepatic presentation, and so acute presentation. And so that's a more frightening and abrupt presentation as well that can be seen. So there obviously can be misdiagnoses and comorbid diseases with fatty liver disease, cryptogenic cirrhosis, alcoholic cirrhosis, autoimmune. So any other liver disease can coexist with Wilson disease. So it's important to keep that in mind. And then I make a special note about the cholestatic liver diseases, because PSC and PBC can also lead to copper accumulation, making them they're particularly a little bit tricky. So in terms of classification of therapy, obviously, we think about initial therapy. It's the time when the person's first diagnosed. Maintenance is when they're have been decoppered for a period of 6 to 12 months. And now we're just trying to maintain their copper at a reasonable level. And then there's the asymptomatic presentation, where someone presents, for example, a 2-year-old who finds out through genetic screening that they have Wilson disease, but they have no symptoms whatsoever and are well. And then, or similarly, a sibling of someone may present it without any symptoms, and the goal is to keep them that way, obviously. And then I also just put a special caveat that pregnancy raises its own set of concerns. How do you treat the pregnant Wilson's patient? So early approved treatments, I mentioned the bowel was one of the first treatments, very painful. It was basically developed as a biodefense for arsenic toxicity, and someone thought, let's check see if it binds copper and see if it'll help the Wilson's patients. This worked to a degree, but was undesirable side effects. Early moved on to penicillamine, which can be quite toxic and disfiguring, trientine, which is less toxic, and then zinc acetate, which, if it's well tolerated and taken well and monitored well, can work quite well to put people in a negative copper balance, but sometimes causes a GI upset or may not be well tolerated or may not be taken carefully because it requires careful dosing away from food, generally multiple times a day. So Trientine, as I said, was only FDA approved for initial therapy as a salvage for after initial therapy, but has gone on to be used for initial therapy now. And so we published controls in ammonium tetrathiomolybdate studies using Trientine, and there are many other manuscripts using it. And recently, Trientine tetrahydrochloride has been approved as a maintenance treatment as well. Just warn that there are several formulations and manufacturers available. Some require refrigeration, some don't. The ones that don't are Trientine tetrahydrochloride, and I'll put out there that there are some that one in particular comes to mind is manufactured by a company called Reddy's that say they don't require refrigeration, but we have our concerns that they may also be more degradable and if they're not refrigerated. So just keep an eye out for that. Risk of neurologic worsening and monitoring while starting. So we generally ramp the dose up if we're starting someone on initial treatment and target weight-based dosing of 10 to 20 milligrams per kilogram as a therapeutic dose and adjust there based on urine copper measures. I just thought I would show briefly, these are patients who were treated with hepatic failure. There's a manuscript we published many years ago, but as you can see, these people had severe liver disease and they were treated with Trientine and zinc, and ascites resolved, child Turcotte Pugh scores normalized, and coagulopathy resolved, jaundice resolved. So even people who are fairly ill can respond to treatment. And these are a series of liver biopsies where you see lots of scar tissue, this sort of bluer hue in these pictures, these nodules. That's at initial diagnosis. This is several years later, and this is even a decade later, and you could see that the scar tissue is really going away, is regressing during treatment. And that's the exciting part about getting rid of the copper injury, is that the liver at times can heal itself. And so we can see fibrosis regression. So something to be aware of and keep in mind, and monitor patients to see if they're doing well. Zinc was originally studied in a thesis in the Netherlands in the 1960s, and then got approved through the FDA Orphan Drug Program. And so basically it's thought to block absorption of zinc from the bowel, and this is its mechanism of action, and then the copper is lost in the stool as the enterocytes slough off. And so here's a radioactive copper study showing that after zinc, there's blockade of copper, radioactive copper absorption, showing that it works. I'll just skip over this in the interest of time, but here you could see that multiple different doses of zinc were studied, and in order to get people in a negative copper balance below that line, the ideal dose was 50 milligrams 3 times a day. That gets adjusted based on urine copper to avoid over-treatment. So with zinc, the main side effect is an upset stomach. Treatment adherence is an issue, generally dosed 3 times daily, and there's a possibility for over or under treatment, and so we monitor urine testing, urine copper, urine zinc levels. And if people are unable to achieve good control with it, we recommend considering transition to Trientine at that point. And it does require individualized drug dosing for penicillamine, Trientine, and zinc, and doses are adjusted based on clinical course, neurologic assessment, hepatic assessment, and copper testing. Liver transplant, I said I would touch on briefly. Suffice it to say, putting functional ATP7B genes into the body corrects the problem of copper metabolism in Wilson disease. although our goal is always to avoid liver transplant and treat with medication. I'm just going to touch on pregnancy briefly. The key points are to monitor patients during every trimester of pregnancy for their stability and be sure that the copper is adequately controlled. Incidence of birth defects is low, but penicillamine is a category D teratogen. Trientine is a category C teratogen. Zinc is theoretically safer, although birth defects are fairly low with both trientine and zinc. And there just aren't large enough numbers of pregnant, Wilson's patients who are having pregnancies to really generate the large numbers to make a definitive recommendation so people can get pregnant with either medication, but we do recommend monitoring carefully during that, and in general, we'll treat with zinc. So future directions, I just want to touch on for a second, and then I'm going to wrap up. The gene therapies we have clinical trials that are actively involved in gene replacement therapies with adeno-associated virus vectors, which are very exciting. There are also gene correction strategies going in and fixing the mutations, which are very exciting. Unfortunately, with 600 mutations, the therapies that are developed may be for the most common mutations, and so at least at first, and that may be limit their application to every patient, because if you only touch on the most common mutations, not everyone has the most common mutations, not everyone will be eligible for those therapies. There are also gene modulation strategies trying to upregulate expression or mRNA stability if someone can still make a functional protein, and those are being actively studied. There are also novel copper chelators on the way. There's a methanobacter-derived therapy. And I also want to touch on improved monitoring, where we're going to have better serum copper assays, as I said at the beginning. So to summarize, the diagnosis of Wilson disease can be challenging or straightforward, depending on the case. The Leipzig criteria can be helpful to get you to think about all the components that go into a diagnosis. Again, I wouldn't automatically say someone has Wilson disease because they have 4 points on the Leipzig scale, or they couldn't have it if they're indeterminate or all the investigation hasn't been done. But it's a very useful criteria that was set up at a meeting in Leipzig, Germany. There's also presentations in the adult patient can range quite a bit from asymptomatic to having neurologic, psychiatric, hepatic, or a combination of those symptoms. And so you have to think about the disease, even if they don't look exactly like the last patient you saw with Wilson disease. Treatment is individualized based on disease state, medication tolerance, adherence, and clinical course. And as I touched on, pregnancy, people with Wilson disease can get pregnant and have children, and we just pay a little more attention to their treatment during that time. So obviously, I want to acknowledge all the funding agencies, patients, investigators, thank the organizers for inviting me, and reference the treatment guidance and guidelines that are available through ASLD and EASL.
Great. Thank you so much, Dr. Askari. Before we move on to a discussion of the patient journey with Alice, I'd like to also acknowledge the support of Miriam, Orphalan, and Ipsen Pharmaceuticals, who have been kind enough to help us make this meeting happen. Without much delay, Alice, maybe we can get into some questions that pertain to the patient journey. I guess the first question I would start with is, let's say you're a person or a caregiver of a person who has symptoms such that similar to the ones Dr. Askari described. What are the challenges of actually getting diagnosed with Wilson disease, at least as you hear them and as you may have experienced them?
I think it's extremely difficult to diagnose. I can just share the reason I'm involved with Wilson Disease Association is my two children, my daughter's 20, my son's 24, both have Wilson disease. My daughter is exactly that 19-year-old patient that Dr. Askari described, who seemed seemingly healthy her entire life and basically presented with end-stage liver disease. I think it's often diagnosed, late teens, early 20s. It can be earlier, later. But, that liver damage is really kind of this silent disease where the person seems seemingly healthy. So it's a very difficult disease to diagnose. And unfortunately, I think when symptoms start appearing, it's often because there is significant liver neurological psychiatric damage, or severity. So very challenging. And because of the range of symptoms, as Dr. Askari described, it can often be misdiagnosed as something else. I do recall a friend of mine who is a doctor, when she learned about my family's case, she said, "Oh, I remember reading about Wilson disease. It was basically a paragraph, and we were told, don't worry about it. Chances are you won't see it in your practice. It affects 1 in 30,000. So it's like, it's a rare disease. Don't worry about it. You'll probably never see it."
Right. I guess a very related question is, in your interactions with folks through the Wilson Disease Association, and maybe even based on your own experience, do you think that the average person who's with Wilson disease has a delayed diagnosis? It takes a long time for them to actually end up getting an accurate and a reliable diagnosis.
I would say yes. This is sort of gut feel, but I think the only way you're diagnosed earlier, really before symptoms appear, is if you do genetic testing because of a sibling or loved one. My daughter presented, and obviously we tested her brother, my son, who does not have as much damage as her. But unless there's a sibling, an uncle who gets diagnosed, then you do genetic testing. But otherwise, it can take potentially years until you're diagnosed, if you get one at all.
Maybe Dr. Askari, you can chime in. Do you often see patients in your practice who, you look back on their chart and then you would say, oh, this person should have been diagnosed with Wilson disease 10 years ago or something like that? Is that a fairly common occurrence, or do most people get referred to you within a reasonable time frame?
Well, I guess I would say I'd be a little more diplomatic about it and say they could have been diagnosed 10 years ago rather than should have, because it is a rare disease. It's always, you do have that sense that there was, many of the patients do have missed opportunities for diagnosis along their journey to a diagnosis. And yes, from our perspective, they should have been diagnosed earlier if someone had only thought of the disease or run the test, look for it, or even interpreted the test they had run correctly, which is even sadder, when someone has, they had KF rings, and they were told they had KF rings, and then 3 years elapsed before they actually get diagnosed, or someone had abnormal liver function tests and someone checked the ceruloplasmin and it was low, and again, the things don't get followed up on or acted on with a sense of urgency. So yeah, yes, I think you're right that does happen quite often, that people could have been diagnosed more rapidly than they were, and some of that has to do with access to available testing too. Insurance companies don't always pay for genetic testing right away without an argument, and access to specialists. Alice is from Canada, and I'm sure the Canadian system has problems with access, just even though they have universal health care, just like our system. And a lot of people are not insured or don't get access to specialists, and so there are access issues as well involved in getting people diagnosed. But yes.
I should share, though, my daughter basically presented with end-stage liver disease. We were blindsided, had no idea that my husband and I were carriers. But I give the emergency room, Kingston, where she goes to school, credit, because her liver enzymes were so elevated. And they said, this makes no sense that a 19-year-old girl has, basically cirrhosis of the liver. So they quickly, within 2 days, diagnosed her with Wilson disease.
That's amazing. Wow.
Yeah.
So
If
I
I
guess
may say something about a patient I had also, Wilson disease may present exactly like what we call now steatotic liver disease. You can have actually fatty infiltration of the liver on a biopsy. If you're not thinking Wilson, you can even have a biopsy and still be told that you have MASH. And I had a case, she presented to us at the age of 18, and she had actually cirrhosis complicated by ascites. But at the age of 15, she was told that she had MASLD and MASH, and she had fatty infiltration of the liver, elevated liver enzymes, and somehow, I mean, she was slightly overweight. She had maybe some risk factors, so no one tested her. So that was definitely a missed opportunity. On the other hand, speaking of testing, also in our clinics, we see many patients presenting at the age of 70 with elevated liver enzymes, and then people checking ceruloplasmin routinely. So I just wanted to highlight that Wilson disease is unlikely to present after the age of 55. Maybe there are some case reports. Dr. Askari, I would love to hear if you've seen any patients present really later in life, but also sometimes we overdo it with ceruloplasmin. And there are other causes of low ceruloplasmin beside Wilson disease. And sometimes we create unnecessary testing by testing patients that are very unlikely to have it. So it goes both ways, I would say, with the testing.
Sure. Alice, what are tips you could give as a caregiver of someone with Wilson disease about how to thrive and actually not only take good care of your loved one, but also take good care of yourself? And as a follow-up to that, what's the Wilson Disease Association wish list? What in an ideal world would you like to see happen to bring more awareness to rare disease in general and Wilson in particular?
Okay, thank you for that. So first question, as a caregiver, you do want to support your loved ones, but I think, and I've talked to a lot of people who are, have been in this journey much longer than I. My kids were just diagnosed 2 years ago. I think you can't let it be all about the disease. I was blindsided and sort of threw myself into research. And I remember both my kids saying to me, where is fun, mom? And is she ever coming back? Because all you want to talk about is Wilson disease. Did you take your meds? Are you drinking water? Are you doing a low copper diet? I think you want to support your loved ones, but you have to have a balance. This is the new normal. And I think I realized, when you have a child, your sole job is to protect them and ensure their safety and health. But you realize you can't control this. This is genetics. It's the new normal for our family. So yes, support them, but don't make it be everything. There has to be room for joy and play and fun. And it can be, it's such a wide-ranging disease. It can be catastrophic and horrible, but it also can be very, very manageable and treatable with, gene therapy and triantine. So, it doesn't have to be as scary as maybe when I first heard the word that, your children have Wilson disease. And secondly, I mean, part of, as a caregiver, I sort of took my anxious worry and angst and tried to channel it into something positive, which is why I joined Wilson Disease Association, Canadian Organization Rare Disorders. How can you take this really a negative experience and turn it into something positive? So I'm very excited to be part of Wilson Disease Association. We have a very long wish list. Greater medical awareness, which is why webinars like this are wonderful. Medical awareness with the current physicians and the emerging physicians coming up through school. Very excited about these gene therapy clinical trials that potentially can offer, a much more robust treatment option. We have a patient registry that we support where Dr. Askari, I believe, is involved with that, where we're tracking patients over a 5-year cycle so we can understand disease progression. It might guide research. There's lots of things. Newborn screening is very exciting as a potential possibility to test babies. I mean, I think about my own children. Had we known when they were babies, the disease progression could have been so much different. And one of the members of our medical advisory committee, Dr. Silhoon Han, is actually developing a newborn screening test. He's piloted it in the state of Washington. Very, very helpful, and excited about that. We're also potentially hoping to create a National Day of Awareness in honor of Dr. Samuel Wilson, the British physician who discovered this disease in 1912. His birthday is December 6th. So it's just really trying to create more awareness. There's, as you know, there's 10,000 rare diseases out there. I obviously have an interest in this one. So it's trying to ensure that there is that awareness.
Great. Well, thank you so much both for at least tonight shedding some light to our attendees, and hopefully those will view this later on this very important, just because it's rare does not mean it's not important. It's certainly important to us and to the patients who suffer from it. We're going to transition to Dr. Alkhouri, who is going to give us an overview of PFIC, and then Emily Ventura will take us through the patient journey after that.
Can you get my screen?
Yep.
Okay. Well, thank you, Dr. Gholam and Neola, for giving me the opportunity to present in this important webinar on progressive familial intrahepatic cholestasis, PFIC. I am an adult and pediatric hepatologist. I did what we call MedPeds training and then did a combined fellowship. So I have a passion for pediatric liver diseases, including Wilson and progressive familial intrahepatic cholestasis, or PFIC. My practice today at Arizona Liver Health is mainly adults and adolescents. I'm not seeing babies with PFIC, but I had a large population I used to follow when I was at the Cleveland Clinic in Ohio. And the more we learn about PFIC, we are realizing that actually these diseases can manifest later in life and can cause unexplained liver disease. And this will be an important topic I discuss today. These are the objectives. First, I'm going to describe the spectrum and clinical presentations of PFIC in children, typically where we see the disease manifest early in life, but also in adults with some late presentations, including some patients that I follow currently. I'm going to discuss briefly the role of genetic testing and some of these genetic panels, like the cholestasis panel, as a way to diagnose unexplained liver disease. And I want to encourage the attendees to utilize these panels. They're actually available to all of us for free and can expedite that journey for patients and make the correct diagnosis quickly. And then I want to discuss very briefly a couple of new therapeutic options for pruritus, itching for patients with PFIC. So when we talk about PFIC, these are heterogeneous groups of what we call autosomal recessive disorders. The main issue is with the bile acid pump. So we all know that bile acids are made from cholesterol in the hepatocytes through a few enzymatic reactions. And then after you make the bile acids, you need to secrete them into the biliary tree. And we need a pump called BSEP, the bile salt export pump. And this is what you see in the figure. And in PFIC, what we call PFIC type 2, there is a mutation that affects the BSEP, the pump, and that leads to a problem with bile acid secretion and getting the bile acids into the biliary tree. This is what we call PFIC type 2 or BSEP deficiency. PFIC type 1 is a problem with FIC1, which is important for flipping phospholipids into the hepatocyte cellular membrane. And when we have a mutation in FIC1, this impacts the integrity of the cellular membrane and the expression of the pump of BSEP, and that's the pathogenesis of PFIC type 1. PFIC type 3, we call it sometimes MDR3 deficiency, multi-drug resistant 3 deficiency. This is an important phospholipid. We call it flippase. So it flips the phospholipids from the inner leaflets of the hepatocellular membrane and gets the phospholipids into the bile. Phospholipids are an important component of bile, and when you don't have enough phospholipids, the bile becomes lithogenic, so you form more stones, and that can lead to also cholestasis and pruritus. So these are the three main PFICs. We've expanded now. We have up to 12 different types of PFICs, but the most common ones are PFIC 1, 2, and 3. Briefly describing the clinical manifestations, PFIC 1 and PFIC 2, they manifest earlier in life. Typically, these are infants that present with neonatal cholestasis. Typically, they have elevated bilirubin, but low gamma GT. They have significant pruritus. Sometimes they have evidence of failure to thrive, and they can be very progressive diseases leading to cirrhosis and portal hypertension in childhood. PFIC 2 tends to be more aggressive than PFIC 1. PFIC 1 has extrahepatic manifestations. In addition to affecting the liver, it's been associated with chronic diarrhea, hearing loss, issues with the pancreas, including pancreatitis, pneumonia. PFIC 2 tend to be more specific to the liver. Very aggressive disease, progresses to cirrhosis early. Pruritus is a manifestation of all these PFICs, tends to be very severe in PFIC 1 and 2. Cholelithiasis, we see it in PFIC 2 and more importantly in PFIC 3 with the issues with phospholipid secretion into the bile. Patients with PFIC, unfortunately, they are at risk for liver cancer, especially with PFIC 2. There is risk of hepatocellular carcinoma. And then with PFIC 3, you can see HCC and even cholangiocarcinoma. PFIC 3 tends to manifest a little bit later in life, and we are learning more and more that even if you're heterozygote for the mutation responsible for PFIC 3, it's called ABCB4, that you can actually develop some manifestations of cholestasis and chronic liver disease. PFIC 1 is more common in the Amish population. So I had a few families I used to follow in Cleveland, Ohio, from Amish descent. We used to call it Byler's disease. It's a mutation in what we call the ATP8B1 gene. Classically, PFIC 1 and PFIC 2 present with cholestasis, but low gamma GT. And the reason is because you have an issue with secreting bile acids into the biliary tree, so there is no really damage to the cholangiocytes because you're not secreting the bile acids. PFIC 1 presents with intense pruritus and progression to cirrhosis, potentially at an early age. Now, I want to spend the next few slides telling you about how PFICs can also manifest in adult patients, and we see more and more of these cases in our practices. And this is just one case where the patient presented at the age of 20 with abdominal pain, and she had an ultrasound showing that she had gallstones, dealt with the pain for a few years, but then in her mid-30s underwent a cholecystectomy. No one suspected that there is a genetic hereditary component to this. And really, she went through life until the age of 60 when she had persistently elevated liver enzymes, issues with elevation in gamma GT, alkaline phosphatase, and elevated serum bile acids. She was ruled out for autoimmune liver diseases that can cause cholestasis like PBC, PSC, autoimmune hepatitis. And she was finally diagnosed with genetic cholestasis. She was found to be heterozygote for the ABCB4 variant that is typically associated with PFIC 3. So we talked about delayed diagnosis in Wilson disease. You can see here in this case, it took this patient 40 years to get the correct diagnosis and understand why she had all these gallstones and elevation in liver enzymes. This is from a study published a couple of years ago looking at patients that had adult onset liver disease without a clear explanation. So it was kind of a cryptogenic presentation of chronic liver disease. And they actually had the genetic testing for the three most common types of PFIC, PFIC 1, 2, and 3. And in this study, 28% of these patients with unexplained liver disease ended up having a mutation in one of the PFIC genes. There was a limited number of patients that had biopsies done, and the majority of these patients showed evidence of cholestasis on the biopsy, but more importantly, that up to 60% of them had advanced fibrosis. So again, these patients can have elevated alkaline phosphatase, gamma GT for years. We test them typically for PBC, PSC, make sure there are no biliary issues, and then we typically just live with it and say, okay, well, you have chronic cholestasis, we're not too sure why. And again, in this study, 28% of these patients had a clear mutation in one of the PFIC genes. So I highly encourage you to test for PFICs in any adult patient with unexplained cholestasis. This is a case that I saw in my clinic a couple years ago. 28-year-old female presented to me with elevated liver enzymes. But what was interesting in her history, she had something we call intrahepatic cholestasis of pregnancy. This is, a classic liver disease, happens in pregnancy, typically towards the end of the pregnancy, where, these women present with severe itching, elevated serum bile acids, and in severe cases, it can lead to stillbirth and the need sometimes to deliver the baby early. I encourage you, after listening to this webinar, that if you have any patients with intrahepatic cholestasis of pregnancy, to call them and test them and to do the genetic testing, because there is a strong association between PFIC3 and the ABCB4 gene and intrahepatic cholestasis of pregnancy. So she came to me with elevated liver enzymes. Like everyone else, she was told that she had fatty liver disease because she had some right upper quadrant pain back in 2016. She got pregnant in 2018, was diagnosed with ICP. She needed labor induction. She had severe itching during pregnancy. After delivery, she continued to have these episodes of severe pruritus. She was tried on cholestyramine with no relief. She underwent a lab chole, and between 2020 and 2022, she continued to have several episodes of pruritus. You can see her labs showing evidence of cholestasis. The routine testing was negative. We did a fiber scan and demonstrated clearly that there's no fatty liver, no steatosis, or CAP score was low at 156. And luckily, there was no significant fibrosis. So we did the genetic testing, and the panel I use is called the cholestasis genetic panel. And one point I want to make today is that, timely genetic testing could be a cost-effective and quick way to make the correct diagnosis. And with these panels, we don't have to test for each genetic test individually. The panel we use, the cholestasis panel, will test for 77 different genes and just one blood draw. And there are more sophisticated ways to do genetic testing, including whole exome sequencing. Of course, when you test for 77 different genes, sometimes you're going to have variants that we call of unknown significance, VUS. Sometimes, you're going to find that a patient is heterozygote for more than one gene, and sometimes they're compound heterozygotes. So we sometimes still don't understand the full effect of, being a carrier for multiple genes in the cholestasis pathway. But again, I encourage you to be familiar with this cholestasis genetic panel. This is the panel I use in my clinic. You can actually order it in your office. It's available for free. This is supported by a grant from a pharmaceutical company. There is a website called testcholestasis.com. So you can go and order it. These are the genes that you will be testing for, and you can see the ABCB genes responsible for PFICs, but it tests for other things that can cause cholestasis, including cystic fibrosis and alpha-1 antitrypsin deficiency. So very comprehensive and free panel. This was the genetic testing results from my patient. So she was heterozygote for the ABCB4 gene. This is the one, if you recall, the one associated with the PFIC3, and the one that's highly associated with the intrahepatic cholestasis of pregnancy. Again, just to explain it on a molecular level quickly, ABCB4 is responsible for secreting the phospholipids into the bile. ABCB11 is the BSEP1. This is the one that secretes the bile acids themselves. And then we also have cholesterol in the bile. When you have a problem with ABCB4, you're not secreting phospholipids. You end up with this lithogenic bile that can lead to gallstones, even what we call intrahepatic gallstones. So when we look at the disease manifestations of ABCB4 variants, two I want you to be familiar with. One is called LPAC, which is low phospholipid associated cholelithiasis. This is, again, typically heterozygote for ABCB4. They tend to have gallstones early in life, history of cholecystectomy at the age of 16, 17, but they can also develop intrahepatic stones. So if you have any patients with intrahepatic stones, any patients that continue to form gallstones after cholecystectomy, I want you to think about PFIC3 and do the genetic testing for ABCB4. The other manifestation that we talked about is intrahepatic cholestasis of pregnancy. We are learning about other manifestations of this gene, including also potentially what we call cholestatic drug-induced liver injury. Controversial, but there's some evidence that, after you take medications like amoxicillin, Augmentin, sometimes we see patients present with severe cholestasis, and some of them could be carriers for this gene, and you can test for it. So these are the scenarios I want you to think about PFIC in adult patients. Anyone with idiopathic unexplained cholestasis, anyone with cholestasis with severe pruritus and unusual presentation. So other things we didn't talk about is patients with what we call small duct PSC may actually be carriers for ABCB4. Patients that have AMA negative PBC also could be carriers. And I just diagnosed a patient of mine. She was told she had PBC for years. She was AMA negative, and we did the genetic testing, and she's positive for ABCB4. Any cases of what we call hormone-induced cholestasis, like ICP, intrahepatic cholestasis of pregnancy. I've had a few women also with what we used to call benign recurrent intrahepatic cholestasis, or BRIC, which is the same as PFIC. If you're heterozygote, they sometimes itch around periods or when they go on contraceptives, so test them for PFIC. And then history of complicated gallstones like intrahepatic stones. This could be related to the low phospholipid associated cholelithiasis. Pruritus is a big manifestation of PFIC and can be a debilitating symptom. So management of pruritus is a key component. Unfortunately, many of the kids I used to follow, this used to be a reason for very poor quality of life, and sometimes by itself an indication for liver transplant. Pruritus is not just a skin symptom. It can lead to irritability, lack of sleep, impaired school attendance and performance, and it has a big burden on the caregiver and family for children with PFIC. Historically speaking, the management of PFIC, we try to support in terms of relieving the pruritus. Also, patients with PFIC, because of cholestasis, they tend to have fat-soluble vitamin deficiency, so vitamin A, D, E, and K you have to replace. And then, of course, monitor for progression to cirrhosis, portal hypertension, managing the complications of advanced liver disease. In terms of help with pruritus, we've tried medications like ursodiol, antibiotics like rifampin might be helpful in some cases, antihistamines, naltrexone, cholestyramine. But to be honest with you, historically speaking, we always struggled with the management of pruritus to the point that we also had some surgical options like biliary diversion. And when all fails, we did liver transplantation. And this is what we mean by biliary diversion. So you can do an external biliary diversion. You take a loop from the jejunum, attach it to the gallbladder, and create an ostomy. And this way you can drain the bile acids. Or you can consider doing also an internal biliary diversion with typically limited success. We have a new treatment option for patients with PFIC I would like all of you to be aware of, and this treatment option is what we call IBAT inhibitors. So IBAT stands for the ileal bile acid transporter. Sometimes we call it also ASBT, apical sodium bile acid transporter. So basically, this bile acid transporter is very important for the what we call bile acid intrahepatic circulation. So as I mentioned earlier, we produce bile acids in the liver. We need the pump to get them into the biliary tree. Then typically we reabsorb these bile acids in the terminal ileum through this IBAT. And in patients with PFIC, if we can actually get rid of some of these bile acids, we may help relieve their pruritus. And this is what we do with these new medications that inhibit this reabsorption at the level of the terminal ileum. So we have two medications that are FDA approved now for patients with PFIC. Both of them are what we call IBAT inhibitors. One is called odevixibat, and here I'm showing the results of the PDFIC 1 and 2 trials. These are patients, again, with genetically confirmed PFIC. They're randomized initially in PDFIC 1 to placebo versus odevixibat. The primary endpoint was the itching score, and we show clear separation between the treatment arm and placebo. And then in PDFIC 2, patients in placebo were actually started on odevixibat, and then we had a new cohort also that was treated with odevixibat with different genetic mutations. And you can see that even in the placebo arm, when you start them on odevixibat, they catch up to the original odevixibat cohort very quickly. So very effective treatment for pruritus. There was also improvement in sleep, quality of life, and serum bile acid levels. And then more recently, also maralixibat was approved for PFIC. These are the results of the March PFIC phase 3 trial. And in the first figure, figure A, you see improvement in pruritus severity, comparison of maralixibat in blue versus placebo in red. Again, very clear separation. Within a few weeks, patients started feeling better. And then in panel B, you see the effects on serum bile acids, and there is a marked reduction in serum bile acids. So two promising therapeutic options for our patients with PFIC. They help with pruritus, no doubt. They help with reducing serum bile acids. And we hope that with longer duration of treatment, we will start seeing an effect on the natural history of the disease and hopefully preventing the need for liver transplantation and preventing progression to portal hypertension. So my take-home message is that the spectrum of PFIC in children and adults is wide, and we should consider PFIC in any cases of unexplained cholestasis, unexplained liver disease. PFICs are not just pediatric diseases. They can manifest later in life, especially PFIC3, and heterozygotes, they can have significant clinical manifestations. I didn't have a chance to discuss all the different types of PFICs. Also, there are other types that are associated with also significant extrahepatic manifestations, including microvillus inclusion disease that can lead to severe diarrhea. So again, as hepatology providers, whether in pediatrics or adults, we need to be familiar with the spectrum of PFIC. Please have a low threshold to order this cholestasis panel. It's available for free. It can give you the answer quickly. Sometimes it can give you multiple hits in different variants. So sometimes I still need help from my geneticist, but for the majority of cases, I do have enough expertise now to interpret the panel and take action based on the results. And finally, we have new treatment options available for our patients with PFIC, which makes making the correct diagnosis more important than ever. So with this, I'm going to conclude and thank you again for the opportunity.
Thank you so much, Naim. I think this presentation is a perfect segue for our discussion with Emily. Emily Ventura, who has been a caregiver and advocate for persons living with PFIC. And so, Emily, I'll start with maybe an initial and perhaps naive question. Is there such a thing as a typical journey for a person with PFIC? What is a typical journey? What is an atypical journey also?
That's a great question. It's going to depend a little bit on your genetic diagnosis and your subtype. I can give you an overview and walk through our journey and talk about what was typical and atypical of that. My daughter was diagnosed with BSEP deficiency or PFIC type 2 when she was 5 months old. She had bruising marks on her back and swelling in her shoulder while she was receiving antibiotics for an ear infection. We actually took her to the hospital and she was in liver failure, and so they diagnosed her 6 weeks later. So she had an ICU stay. It took some time for her coagulopathy to correct. 6 weeks later, she had a biopsy to confirm genetic tests had come back and she had PFIC type 2. I will say that seems like a typical path to diagnosis for many patients with PFIC type 2. I know type 1, type 3, and some of the other types present a little bit differently, but that bruising manifestation comes up quite often with patients that I speak with. Pruritus set in shortly after. My daughter was diagnosed 12 years ago, and so there were no medical options available to her. So surgical options were what we had to choose from. She did go through the partial external diversion surgery that Dr. Askari just mentioned. That surgery unfortunately did not work for her. It did not improve her pruritus, and 3 years later, she was listed for liver transplant. That also, the surgery and the IBAT inhibitors, the interventions work for some patients and not all. And I think there is quite a bit of knowledge now to understand which genetic subtypes will, or which genetic diagnosis will respond to medical surgical interventions and which won't. In hindsight, my daughter has a very specific genetic subtype that would not have responded to these diagnoses, but we didn't know that at the time, so she went through surgery. Her liver transplant journey, she was transplanted at age 5. Again, that time to transplant for those who have a more severe progression towards disease, typically before age 10. So hers was quite typical at age 5. Transplant itself went quite well, but the journey post-transplant was nothing typical. She had 5 episodes of rejection over 7 years, and just last year she suffered a recurrence of her disease post-transplant, which is something that happens again in the small subpopulation of patients with BSEP2, but it does happen. It's alloimmune BSEP deficiency, which causes her essentially to relapse in her disease. Again, that's atypical for most, but for this specific subtype of PFIC2, it is common. And there's other post-transplant manifestations and other subtypes. PFIC1 in particular has a very hard time post-transplant with the extrahepatic manifestations. And so that's almost a disease in itself.
So you're obviously someone with a high level of health literacy for obvious reasons. So you're able, I think, to navigate this very complicated process as a caregiver and a mom. It looks like better than, I would say, 99% of people. But what advice do you have for those who may not have the same level of health literacy, may be searching for resources, searching for ways that they can deal with this with help, I guess is the best way to put it.
Sure. I will say I cheated. So I was an ICU nurse for 10 years before I worked for the foundation. So before I had my daughter, I was a nurse. And so that contributes a little bit, but as a parent, it's completely different. I think one of the best pieces of advice I could give, especially for a rare disease, is just to become educated, ask questions, and learn how to be a health advocate. And I think really you need to build a relationship with your doctor and your care team. I think that's so important, especially in a rare disease. Oftentimes, I mean, I ask a lot of questions, whether they're educated questions or not. Nothing's a dumb question, because oftentimes my questions lead to curiosities in her healthcare team that then helps to better support her diagnosis. And I think that's just crucial to build that relationship with your clinical care team.
Now, in your advocacy work through the PFIC network, have you encountered some patients who were diagnosed as adults? I know Dr. Alkori made a point of emphasis about that, and maybe Naeem, you could chime in about that too, please.
Yeah, I will say I've been hearing from adults more and more over the past few years. I anticipated this question, so I pinged our patient registry just yesterday, and I found we have over 15 who are diagnosed. I think it was 22, but we're just getting into this data right now.
Sure.
And there were 10 who were, there were 10 who were diagnosed after the age of 10. And so I think we are connected with patients who are diagnosed later in life. We are connected to adults. Adults seem to experience, a similar journey, but a lot more questions because they're still trying to understand, do I even have PFIC? Am I going to have the same trajectory as these children who have PFIC? Is my disease going to progress and need liver transplant? Those are some of the common questions that we get. And so I think, I was really interested. I actually have a lot of questions for you, Dr. Alkori, so you can expect that I'll be pinging you after. But I think there's been an uptick in adults who's connecting with us, absolutely.
Yeah, and as I showed in that study that had some histologic data, that many of them have advanced fibrosis. So it's not just pure cholestasis and just itching here and there. Sometimes it can lead to progressive liver disease, and again, sometimes we're kind of making the correct diagnosis after these patients received another diagnosis for many years.
Right.
This is something that with the availability of genetic testing and the fact that this is available for free, it makes it easier for me to test more and more patients. You bring up very important points. Number one is, the truncating mutation with PFIC2 being less responsive to medications like odevixibat and maralixibat. And this is something that can be determined ahead of time with genetic testing, and the aggressive nature of the disease, but also the recurrence after liver transplant, which is in contrast to Wilson disease. Typically, when you transplant someone with Wilson, we say, you're good, you're going to be okay if they don't have, significant already neurologic manifestations. They do pretty well, but with PFIC, there's that potential for recurrence. And then, some extrahepatic manifestations like PFIC1, they can develop very severe steatohepatitis after transplant that can lead to progressive fibrosis and in some cases even cirrhosis in the graft and portal hypertension. I had a patient that had all these issues. We had to do TIPS post-liver transplant, and also severe diarrhea. Diarrhea can get worse after transplant, and we still learning. We really don't understand mechanistically why this happens, and very fascinating and unfortunate that even with the transplant, you still have these extrahepatic manifestations.
Emily, last question. We asked this to Alice too, what is your wish list, or what is the PFIC Network's wish list in terms of what we can do to raise awareness and make the plight of folks living with PFIC better?
Yeah, it's a great question. For us, we wish that every person with PFIC has a genetic diagnosis and that they understand their diagnosis, and that every person with a PFIC diagnosis will have a treatment pathway that is accessible to them, regardless of subtype, regardless of age, regardless of geographic location. So if we can accomplish those two very simple tasks, then I think we'll be well on our way to improving lives of families with PFIC. I will say we have PFIC Awareness Day is coming up October 5th. So you'll be hearing more, from PFIC and, hoping to send a broad message. And I think this, the information that was shared today is definitely very important message just to share. So just have that on your radar. And that's one way that we can collectively spread disease awareness as well. Just come together on October 5th.
Great. Well, the Neola staff, which I think I would be remiss if I didn't thank for putting this together, Scott Suko, our executive director, Mark Abbott, our program manager, and Michelle Dubs. I think they hear you and they will try to amplify the message too, so that we can make sure that we raise awareness on October 5. I'd like to thank our attendees today for joining us. We apologize for some of the technical issues at the beginning, but I think we ended up having an absolutely wonderful review of two important rare diseases. We thank all our panelists. You will be able to watch this on our YouTube channel at a later time if you would like to, or if you'd like to link to it. And we certainly hope that you have a good evening and see you at our next activity. Have a great evening.
Thank you. Thank you for having us.
Thank you.
Thanks so much, everyone.